diphtheria because if you encounter any case of diphtheria, so that immediate treatment can be started. Though we are studying the microbiology of diphtheria, but diphtheria is a clinical diagnosis because you have to start treatment immediately. We cannot wait for the microbiological confirmation. So diphtheria, what is the motto of reading? That even if you encounter a single case of diphtheria, you can suspect and start the treatment. So before we go to the diphtheria, I have intentionally included the streptococcal pharyngitis. That is the commonest. Let them get in. I have intentionally kept few slides of bacterial pharyngitis of streptococcus or beta hemolytic streptococcus because that is the commonest differential diagnosis, and that case you will enter many times in your clinical career. But diphtheria you may or may not see in your clinical career a single case of diphtheria after the vaccination has started. So clinical case of diphtheria is very rare. So what are the learning objectives in this class? So that you can learn about diphtheria, you can differentiate between streptococcal pharyngitis and diphtheria, and the diagnostic procedure is almost the same. It is the most common upper respiratory infection you will encounter. Just what are the causes of pharyngitis? That may be bacterial pharyngitis, there may be viral, and among the bacterial pharyngitis, two most important bacteria are beta hemolytic or group A streptococcus and diphtheria. So streptococcus and corynebacterium diphtheria are the two most common organisms. Please don't talk. These are the rare causes of bacterial pharyngitis. Other hemolytic streptococci, group C and group G, Arcanobacterium, Fusobacterium, Mycoplasma and Neisseria. Now streptococcal meningitis is already covered in the last class. So I will just show you a picture of streptococcal pharyngitis and how it is. This is the streptococcal pharyngitis or tonsillopharyngitis. There is a white patch of tonsillar fossa, that is the streptococcal pharyngitis, that is the cause of localized tonsillitis, or it may cause diffuse pharyngitis. So you can see the enlarged tonsils covered with white fibrinous exudate. Now how we will diagnose? The differential diagnosis, as I have told, is diphtheria and viral pharyngitis. So the diagnostic method would be the same whether it is a streptococcal pharyngitis or diphtheria. Same culture, and that will be gram-positive cocci in chains. Now we come to the today's topic, that is diphtheria. What is the causative agent of diphtheria? Corynebacterium diphtheria. What is the meaning of corynebacterium? Can anybody, what is the meaning of corynebacterium? What is the meaning of corynebacterium? Means club-shaped bacilli. Corynebacterium means club-shaped bacilli, and this is one of the example of gram-positive bacilli. What are the other example of gram-positive bacilli? Can anyone tell the other names of gram-positive bacilli which will you encounter? This is one example of gram-positive bacilli, Corynebacterium diphtheria, or Corynebacterium is the gram-positive bacilli. Other examples are Bacillus species, Clostridium. Bacillus or Clostridium are with spore, gram-positive bacilli with spore. Corynebacterium is non-sporing. Other gram-positive bacilli examples are Listeria and Actinomycetes. So these are few examples of gram-positive bacilli. Now Corynebacterium diphtheria is highly infectious. Corynebacterium diphtheria primarily infects the throat, tonsil and larynx. So that involves the respiratory tract. That is the main causes an exudative pharyngitis and membranous tonsillitis. Now, what is the history? In 1826, Pierre Bretonneau give the diphtheros, meaning leather-like. Why he has given a leather-like? When we go towards the next pathogenesis or the disease process, there will be a pseudo-membrane. A leather-like membrane usually forms over the tonsillar fossa. That's why initially the history was first given the name diphtheros, meaning leather-like. First observed by Claves in 1883, first cultivated by Loeffler. So that's why diphtheria bacillus is also called Clave-Loeffler's bacillus. So why it is called a Clave-Loeffler's bacillus? First observed by Claves in 1883 and the first cultivated by Loeffler in 1884. Now gram-positive, it is a non-capsulated, non-motile bacillus. Diphtheria is non-capsulated, non-sporing, non-motile bacillus, club-shaped swelling of the both sides of the bacillus. That is diphtheria. This is the staining method of one of the staining method. I will come to the staining method later on. Now this is the difference. What is the arrangement? Whether you do gram stain, whether you do Albert stain is a specific stain for diphtheria. The arrangement is typical. What is the arrangement? Arrangement is called Chinese letter pattern arrangement. Chinese letter pattern or cuneiform arrangement, this is a typical arrangement. So when a sample is sent to you for a throat swab, if you cannot confirm from the staining that it is Corynebacterium diphtheria, but you have to inform the clinician, or the clinician will need to know whether you get a V or L-shaped Chinese letter pattern arrangement gram-positive bacilli, so that he or she can start treatment of diphtheria. So this arrangement is a typical V or L-shaped Chinese letter pattern. The second specific point of diphtheria is the metachromatic granule. Metachromatic granule present at ends of both poles of the bacilli. So what is the difference between the Corynebacterium diphtheria is a pathogenic organism? You will encounter other gram-positive bacilli that are common cells in the throat or other skin. Those are called diphtheroids. They are not Corynebacterium diphtheria but diphtheroid. What is the difference between the in the staining method of diphtheroid and diphtheria? This Corynebacterium diphtheroids are non-pathogenic, they are having a palisade type of arrangement, not the Chinese letter pattern arrangement. Diphtheroids, non-pathogenic, common cell, they produce in staining a palisade type of arrangement. Now the metachromatic granule, a short note can come. Metachromatic granule is one of the most important identification point of Corynebacterium diphtheria. When you do typical particular stain or specific stain for Corynebacterium, they consist of polymetaphosphates. So they are also called polar bodies, wave earnest granule. They are composed of polymetaphosphates. They stain strongly gram-positive compared to remaining part of the bacilli. They are bluish purple metachromatic color when stained with specific stain. Loeffler's methylene blue is one of the stains where it was bluish purple metachromatic granule. Now you must remember which part, that is the metachromatic granule consists of polymetaphosphates. If you forget other part, at least remember it consists of polymetaphosphates. They are better stained with Albert stain. Remember the name. Whenever you are studying Corynebacterium, Albert stain is specific stain for diagnosing Corynebacterium. So remember the name of Albert stain. If you forget other stain, Neisser stain, Ponder stain can be used. But commonly what is used in the laboratory is Albert stain. Albert staining is the staining method used in staining Corynebacterium. And this bacilli looks like greenish and the dark purple like in the metachromatic granules and dark purple light. So this is the staining method. Loeffler serum slope. What is low serum slope? Low serum slope is a specific media. Whenever you get any suspected case of diphtheria, you must inoculate it in the low serum slope. What is the why this media is used? There is a two importance of this media, low serum slope, or in short LSS. The colony appear within 6 to 8 hours. That is the earliest, because turnaround time must be less. When you are diagnosing diphtheria, turnaround time must be less. So LSS is a specific media, that is an enriched media. So colony appears within 6 to 8 hours, and if you stain from that colony, the secondary stain, the metachromatic granules will be more prominent. So this is the two advantage of LSS. Low serum slope, the colony appears within 6 hours, and the metachromatic granules are more prominent when we inoculate in low serum slope. So this is again some recapitulation. Causative agent of diphtheria, this is pleomorphic gram positive, possess polymetaphosphate. Cornybacteria have been typed based on, this is biotyping, gravis, intermedius and mitis. It was now commonly not followed in all laboratory, but this is the biotyping of Cornybacterium diphtheria. It is divided into Cornybacterium diphtheria gravis, intermedius and mitis. And their pathogenicity is due to toxin, not due to bacteremia. This, remember, all the disease produced by the respiratory diphtheria was due to the toxin in the diphtheria, not due to bacteria itself. So there is no bacteremia. When it is a pathogenesis, we will go to the pathogenesis of Cornybacterium diphtheria. It is mostly due to toxin only. No bacteremia is there. Now, virulence factor. What are the virulence factors? One is toxin polypeptide chain composed of two fragments A and B. So, whenever you get any toxin and you get an A and B part, A is always the active part and B is the binding part. So, in which part it binds? Epithelial growth factor. Epithelial growth factor is the receptor where this toxin binds. Epithelial growth factor is the receptor where this toxin part B binds. Fragment A, what is the mechanism? It causes ADP ribosylation of elongation factor 2. Remember this pathogenesis, ADP ribosylation of elongation factor 2. What happens when elongation factor 2 leads to inhibition of elongation factor 2, and that leads to inhibition of translation of protein, and the protein synthesis is disturbed. So this is the mechanism of diphtheria toxin. It is ADP ribosylation of elongation factor 2, inhibition of elongation factor 2, inhibition of translation step of protein, and protein synthesis is inhibited. Next, toxin, fudge coded, beta cornifudge. Fudge coded means that is a cornifudge, a virus. Still it is in the Cornybacterium diphtheria bacilli. Till then it is toxigenic. If the cornifudge goes out of the bacillus, the Cornybacterium diphtheria become non-toxigenic. So this tox gene or the virulence factor is only expressed when it is infected with cornifudge, a fudge virus. So that is called fudge coated. Iron concentration 0.1 milligram per liter. Why iron is needed? It usually a gene regulator protein is there, that is DTXR. DTXR is capital. DTXR, that is by negative suppressor method, the iron using as negative suppressor of DTXR, and this toxin is expressed. So second part is this part. Even if you don't remember the DTXR, you just remember it is fudge coated. The bacteria must be infected with the bacteriophage to express the toxin. And the second part, iron is needed in a very small 0.1 milligram per liter for expression of the toxin. Now here another point, other species except other than Cornybacterium diphtheria, Cornybacterium ulcerans and Cornybacterium pseudotuberculosis also produce the toxin. When we will go to the laboratory diagnosis, remember how will you differentiate between Corynebacterium diphtheria with Corynebacterium ulcerans and Corynebacterium pseudotuberculosis. A single test can be done to differentiate these three. What is that test? That is urease test. Urease test, Corynebacterium diphtheria is urease positive, negative, sorry. Corynebacterium diphtheria is urease negative, and Corynebacterium ulcerans and Corynebacterium pseudotuberculosis are urease positive. This is one of the MCQ. The type of infection caused by potentially toxigenic Corynebacterium diphtheria has changed over the decade. Why it is changed? Because the advent of vaccination and universal vaccination has led to the decrease in the respiratory diphtheria. But what we can get is some atypical disease, and mostly those atypical diseases are cutaneous diphtheria or other myocarditis, endocarditis, septic arthritis type. Severe and recurrent episodes of sore throat. These are the alternate symptoms of diphtheria. Toxoid is used for vaccination. What is the vaccine used in diphtheria? DPT. So DPT, what is the course schedule of DPT? When we give DPT? DPT, what it contains? D for, that is diphtheria toxoid and tetanus toxoid, and P for whether it is a toxoid or killed, which is pertussis. Pertussis is a killed pertussis. Now we are also using acellular pertussis as part of DPT. So diphtheria is a toxoid and tetanus toxoid, and pertussis is killed pertussis vaccine. That has converted to toxoid. Now how will you convert the toxin into toxoid? And toxin, for toxoid form of toxin where virulence is lost but immunogenicity or antigenicity is retained, so that it can be used as a vaccine. Toxoid formation. So how you can convert the toxin into toxoid? That can be by using of low pH, use of formalin, that can lead to prolonged storage. These are the 3 points, but it's commonly produced by use of formalin. The diphtheria toxin is converted to toxoid by either using formalin, it can be in low pH or prolonged storage. Now what is the strain used in diphtheria toxoid? That is specific. This is another MCQ question. Park-William 8 strain. Park-William 8 strain is used for production of the vaccine or the toxoid. Loeffler limit of flocculation unit or LF unit. Can anybody tell what is the amount of Loeffler unit used in DPT vaccine? D, that is 25 LF unit is used in DPT vaccine. Now pathogenicity. What I told initially and again, the diphtheria or the respiratory diphtheria is due to toxemia only, but never a bacteremia. So bacilli are non-invasive, they secrete the toxin, spread via bloodstream to various organs. And toxin responsible for all types of manifestation, local and systemic configuration. So this is the main point of pathogenesis. It is mainly due to toxemia, not due to bacteremia. So if you use antibiotic only, it will not work. When antibiotic can work, when you go to the treatment, antibiotic only work within 6 hours when the toxin has not been released. So the antitoxin has to be given in the treatment of diphtheria. That is the main point why we are learning the pathogenicity. It is due to the toxemia. Respiratory diphtheria is the most common. What is the tonsil and pharynx? Phaseal diphtheria. Phaseal means tonsillar diphtheria. It can also lead to the laryngeal diphtheria. What will be the symptom of laryngeal diphtheria? Tonsillar diphtheria may or may not cause breathing distress, but if it involves larynx, there will be stridor. That is a stridor obstructive airway disease. The stridor will appear, that stridor will prove that the larynx has been involved. So respiratory diphtheria, three common parts, tonsil and pharynx, and larynx can also be involved. If the larynx is involved, there will be inspiratory stridor, and that can be, the sound can be heard even if you go near to the patient. That is, stridor occurs due to the involvement of the larynx. So incubation period is 2 to 7 days, usually average 3 to 4 days. Facial diphtheria. You see the picture, there is the greyish white membrane over the tonsillar fossa. I will show a better picture. An inflammatory response leads to necrosis of the epithelium. That necrosis epithelium and exudate and mucosal ulcer lined by tough, leathery, greyish white pseudomembrane. So how you can say this is a pseudomembrane, not a true membrane? How can you differentiate clinically it is a pseudomembrane or true membrane? So if you try to remove the pseudomembrane, as it is not a proper membrane, it will not come out. It will come difficulty to come out, and there will be bleeding spot. When you try to remove the pseudomembrane, that's why it is called not a true membrane, it is a pseudomembrane. So that is pseudomembrane covering the tonsils. Remember the term pseudomembrane and how it forms due to the necrosis of the epithelium, necrosis of the tissue, the exudate formation and mucosal ulcer. That is another picture. You can see by the light, there is a greyish white membrane inside. This is a more clear picture. Strongly adherent. The pseudomembrane is usually typically strongly adherent to the tonsillar fossa. If you try to remove the pseudomembrane, you can see the bleeding spot below underneath it. That is called pseudomembrane. Extension of pseudomembrane, that may lead to, there is another term, bull neck appearance. That is a tonsillar swelling leading to involvement of cervical lymph node and formation of bull neck. Neck edema, involvement of cervical lymph node, and what other features? There will be foul breath, thick speech and stridor. That stridor is due to the laryngeal involvement. So this, you remember this bull neck appearance, but it is very late. If you get the bull neck appearance, the patient will be in a dire state. Now this is a classification. Diphtheria classified on clinical severity. There may be malignant or hypertoxic diphtheria. There may be septic diphtheria and hemorrhagic diphtheria. So malignant means severe toxemia, marked adenitis, that is bull neck, death due to circulatory failure. Septic leads to ulceration, cellulitis and even gangrene around the pseudomembrane. Hemorrhagic, bleeding from the edges of the membrane. There may be epistaxis, there may be conjunctival hemorrhage, purpura and general bleeding tendency. So these are clinical classification of diphtheria. Common complication, there may be asphyxia, there may be myocarditis, there may be acute circulatory failure, post-diphtheritic paralysis, polyneuritis can occur involving the cranial nerve, local necrotic changes, non-toxigenic strain. Here are two MCQ I have not intentionally given in what is the commonest muscle, first muscle involved in cornybacterium diphtheria. That is diphtheria, what is the ninth cranial nerve is involved? The muscle which is first involved in diphtheria is palatopharyngeus. Palatopharyngeus is the first muscle that is involved in diphtheria. Now what is the first muscle that is involved in tetanus? Tetanus you have not already studied, but tetanus, remember, masseter, because the first symptom is lockjaw in tetanus. Masseter is the first muscle that is involved in tetanus. So what can occur? There may be other organ involvement, there may be myocarditis, there may be neurological complication, and among the neurological complication it can involve the cranial nerve and peripheral nerve as well. Neurologic manifestation are toxin-mediated, non-inflammatory, demyelinating disorder. So what type of neurological complication? It is basically a demyelinating disorder, cranial nerve involvement, peripheral neuropathy, myocarditis typically associated with What are the features of the myocarditis? There may be arrhythmia or there may be dilated cardiomyopathy. This is the whole pathogenesis in a single slide. For recapitulation, what is the main pathogenesis part? Is the penetration of bacilli, formation of bacilli, no bacteremia, penetration of bacilli,